Welcome to Genomics Matters. Genomic information is increasingly used as a diagnostic tool to identify the underlying genetic causes of cardiovascular disease. This can be crucial for accurate diagnosis and appropriate management. Genomics plays a pivotal role in cardiovascular health by contributing to our understanding of the genetic basis of diseases, enabling risk prediction or an individual's predisposition to cardiovascular disease, guiding preventative measures, as well as enabling targeted interventions, personalised treatment strategies, and facilitating ongoing research in the field of cardiology. In this podcast, we aim to explore this topic, and I'm delighted to welcome to this episode Dr. Rhys Beynon, cardiology consultant, Claire Hopton, consultant in genomic medicine, along with two members of our patient and public voice panel, Paul McGreavy and Dave McCormick. Thanks again, everybody, for joining us today. So we'll sort of set the scene. Rhys, if I can come to you first, what is genomics and what is its role within cardiovascular health?
Yeah, thanks, Barbara. I think it's best I do this segment with Claire, really, as the geneticist in the room. Although I'll give you a kind of layman's view of that, as that's kind of what I am. I'm not a geneticist. Essentially, our bodies are made up of proteins, little building blocks of life, and those building blocks are coded for by our DNA, our genetics, our genes, essentially. We have different genes that code for different bits of our body. Some codes for our eyes, some codes for our nose, some codes for bits of our skin, everything, our hair. And certainly from a heart point of view, there are some fairly key genes that bits of DNA genes that are coded for to produce our hearts. Some of those genes, those groups of DNA, which is what genes are, code for the heart muscle, the heart muscle cells. Some of them code to produce building blocks that join the heart muscle cells together. Some code for building blocks that support our aorta, the main blood supply that comes out of the body, and some code for what we call the channels in our heart. Our heart is a collection of muscle and electrics, much like the electrics in your house. We have electrics in our heart, and those electrical wires are coded for, and the electrical opening and closing of those electrical wires are coded for as well by genes. So essentially, we are just building blocks coded for by these genes in our body. As a cardiologist, bits of our body go wrong or develop disease as we get older, and that can at times be due to abnormalities in our genes, our DNA, and with that we'll develop heart disease as a result of that. Claire, have you got anything else you want to kind of fill in terms of genetic background?
So I think that's a really good explanation of things. So I think, as Rhys said, alterations in certain genes can cause a variety of different heart problems. For example, problems with the electrical activity in the heart, and we call these inherited arrhythmia syndromes, or problems which cause alterations in genes which cause problems with the heart muscle, so cardiomyopathies, and these are typically the kind of things that we see in our cardiac genetics clinic.
Yeah, so as Claire said, you know, people come to see me, and we talk to them, and some of them have problems with the heart muscle, for instance. Now, the commonest reason for people to have problems with the heart muscle is they've had a heart attack. That's usually caused by a problem with the pipes, the arteries in our heart, which become furred up and then eventually blocked, and that causes a scarred heart. That's the commonest form of cardiac disease worldwide. And I think we'll come to that later on, because I think that's one area of interest from a genomics area that is the part of the future, but certainly not part of the present or past. Genomics in the present and past have been very much about relatively rare diseases rather than the common diseases that cause stents and heart attacks. And by that, I mean, by rare disease, I mean things that affect certainly less than 1 in 1,000, 1 in 500, 1 in 1,000 of the population. And some of those are heart muscle diseases that are caused by alterations in the genes that code for the proteins that build the building blocks of our heart muscle. So when I talk to families, they tell me I've got a problem with the heart muscle. They tell me that they've got no problems with the arteries, and we start asking why have they got a problem with the heart muscle. And as we talk to them, it becomes clear quite regularly that the other family members have got problems with the heart muscle. Either the heart muscle if they've got a heart muscle problem, or the heart electrics if they've got a heart electric problems, and there are some rare causes of that. And then also problems with the heart aorta, the aorta itself that can cause problems. So yes, quite a lot of this runs in families, and then Claire and I and the genetics team will often talk to them about the possibility of genetic testing to try and find an answer that might explain what's going on in their family.
That's great. Thanks, Rhys and Claire. I think they're saying you've really sort of, because the next question I was going to ask was that sort of concept of the inherited cardiac disease, but that the role of genetics in their development. So if we could take that a little bit further, so what do you feel, and obviously this is to both Claire and Rhys, what do you feel the potential challenges are and the limitations are with regard to genetic testing within the context of cardiovascular health?
So I think one of the major challenges at the moment is that although we can do genetic testing to look for alterations within certain genes which may be associated with heart muscle problems or problems with the electrical activity within the heart, we know that within families where we do identify one of these gene alterations, not everyone within the family who carries the alteration actually develops problems. So we call this incomplete penetrance. And at the moment, we don't fully understand why we see this. We think that there's probably a number of different factors at play, including environmental factors and possibly other genetic factors. But I think in time, further research will help us understand this more. And I think in the not too distant future, there may be further testing that we're able to do to kind of clarify someone's risk better and help us direct treatment and screening more appropriate within these families.
Yeah, I kind of echo everything Claire said. I saw a gentleman at 12 o'clock today in clinic who was exactly this. He has a genetic change, what we call a genetic variant, that he's inherited from his father. And his father definitely has heart disease that's caused problems in the past. And he's inherited this genetic variant, and he's 30, and he wants to know, is he going to be the same as his dad? And I had to sit and talk to him about in clinic, saying, not necessarily. He might go through the whole of his life and be normal from a heart point of view, despite inheriting this change. And this is a real, as Claire says, it's a real challenge for us, because you're trying to guide families about what's going to happen in the future and what's going to be their risk of events in the future. The young man I spoke to this morning had a family history of people dying suddenly quite young. I think for me, this is perhaps the most exciting area that we have in genetics at the moment, because these questions that Claire and I battle with, have challenges with every day, are starting to provide answers. Those answers are starting to be provided, at least in part, by the results of very large international trials. Without wishing to get too detailed, about 15 years ago, the UK recruited 500,000 people age 40 to 60 to a big research trial called the UK Biobank. And the UK Biobank announced in November that they had completed genomic testing for all 500,000 people. As well as completing genomic testing, they can see what diseases those 500,000 people are going to develop or have developed in the last 15 years, as well as all sorts of medication they've been taking and lifestyle decisions, how much exercise they've had in those 15 years. And I think that this very large UK biobank research trial is going to start to give us answers as to potentially why some people, like my patient this morning, may go through life having no problems, but whilst some other people might go to have problems. And I think that will be really powerful. I spend a lot of time in clinic at the moment saying to people, I don't know what's going to happen to you, but I'm going to see you again in 4 or 5 years' time, because I think I might have some more answers in 4 or 5 years' time. And that's, as I say, that's quite an exciting place to be. I think the other thing to say about that big research trial, the UK Biobank and other similar ones around the world, is that they may start to give us answers as to why some people develop common diseases at a younger age. I see as a cardiologist some people coming into hospital aged 45, 50 with a heart attack, a very common disease. Some of them have smoked all their life. Some of them have lots of risk factors, diabetes, and you can start to understand why that might be, but others don't. Some of them come age 45 with a heart attack, or 50 and having had a coronary stent, and you don't know why. They're not diabetic, they haven't smoked. But if you talk to them, you start to find that some of them have a family history of similar events. So I think the UK Biobank and the research trial of 500,000 people will start to give us potentially answers, some answers, not all the answers, but some answers as to some of these common diseases in future. Why do some people get heart attacks at a younger age than others? And again, that's going to be really powerful, I think, really powerful when you're dealing with families who have heart attacks at a young age. Powerful to be able to guide them about what their risk is in the future, but also, most importantly, powerful that you can start to talk to them about preventative medication that might stop those people age 45, 50 developing heart attacks. So I'm a cardiologist, I'm not a geneticist, but I think the developments in genetics over the last 10 years are fascinating and extremely exciting for what we can potentially deliver in 5 to 10 years' time.
Absolutely. Thanks, Rhys and Claire. I think it's really present moment to bring Paul and Dave in at this point. So Paul, if we can come over to you, because obviously you have lived experience of heart attacks, cardiovascular health. So if I can sort of pass over to you for you to be able to share your experiences and your thoughts.
Yes, thanks, Barbara. I think you're right. From what both Claire and Rhys have said, it resonates with me quite a lot. If I give you a bit of background to my own particular case, and then we can discuss where I might go with this. I was a very fit 62-year-old with no personal record of heart trouble, and I had a heart attack. I was a runner, a mountain biker, no problems at all. I was fit, never smoked, moderate drinker, no other illnesses, but I had a heart attack. Obviously, I recovered from it, which is why I'm here talking to you now. But after my period in hospital and having had a stent fitted, I was diagnosed with ischemic heart disease. It was one of the pipes in the heart that was blocked and was cleared, fortunately, by the cardiologist. I started to look at any kind of family history that my family had, particularly my paternal family, because I knew that my father did have a heart problem. And I discovered that there was several generations of people having heart disease and, in fact, dying from heart attack, which is very, very worrying for someone who's in his early 60s, and suddenly you discover this history that wasn't there before. So yes, I've got kind of flesh in the game here. And what I wanted to do was to find out, because I have children and grandchildren, I wanted to find out what their chances are of actually continuing the noble tradition of having heart attacks within the McGreavy family. I'm still trying to find that out. You know, I have one son who is very fit. He's a retired now international lacrosse player. I have grandchildren in their how old? 7 and 4. But nonetheless, I need to find a way of raising the issues with my son in order to work out what strategies he could employ, because it's very, very difficult for me to start a conversation with a basic lack of knowledge. So I am really looking into genomics in order to find out what I can talk to my son about and how I can advise my son. So that's something that I really need to find out about. Personally, at the moment, genetic testing isn't something that I have committed to, but I am curious.
Claire, do you want to speak or do you want me to? I'm happy either way.
So I think at the moment, in terms of genetic testing, like I was saying before, in the cardiac genetics clinic, we largely see people who have conditions that are due to alterations, mainly due to a single gene alteration, rather than perhaps what we would call a polygenic risk. So alterations within many genes across the genome. And I think in terms of things like having heart attacks and things like that, I think that's more likely to be due to a polygenic risk. So many alterations across the whole genome, in combination with kind of environmental factors as well. I don't know what your thoughts are, Rhys.
Yeah, I mean, I would echo what you said. I think I would say to you, Paul, that we don't have answers for you at the moment, but I think we might have in 5 or 10 years' time. And I guess I come back to the kind of UK biobank that I was talking about, those 500,000 people in the UK who volunteered for this trial and had their blood taken, because we know that unless you have what we call familial hypercholesterolemia, where your cholesterol level is sky high, that heart attacks are not caused by one single genetic problem. Of all the people aged 60 who've got heart attacks, less than 1% of them have got sky high cholesterol levels. So actually, we know it's not caused by one single genetic problem, but we're starting to understand that it's potentially caused by hundreds of genetic changes, each of which contribute a very small amount each time to the risk. But if you have too many of those genetic changes, then your risk goes up significantly. That information, trying to find those hundreds of small genetic changes that might add up, we're only starting to look at through this UK Biobank whole genome sequencing data that we're starting to get. And I think it's going to take, I mean, if you imagine, I think it's worthwhile thinking about the size of the problem. Your DNA, all of our DNA is 3 billion letters long inside every single cell. So what we need to do is take all of those 3 billion letters in all of those 500,000 people and push that through a computer. I mean, it's enormous numbers of people, enormous numbers of data, and try and follow them out. And I think over the next 5 to 10 years, researchers will spend time looking at that with very powerful computers to try and find out what all those hundreds of little areas of your DNA that affect your risk pool that have led to this. And I think that gives you two things. I think by looking at those hundreds of areas, you can start to find disease processes, or what we call biological processes, that they're contributing to. Because for you to have a heart attack, you have to have an artery that furs up, and then that artery has to crack. So it's quite a complex process biologically. So by finding these hundreds of areas, we can start to understand that biological process better and start to discover more treatments for your children in the long run, because at the moment we've probably only got statins really that make a difference. And secondly, by using those hundreds of areas, we can calculate how many of them you carry or your children carry, through what Claire was talking through, a polygenic risk score. And then we can give your next generation some idea as to what their risk is and what treatments we can give them. So I think that data will come, but it will come in the next 5 to 10 years as people work through that enormous amounts of data that these biobanks are producing now.
So my first question was almost about philanthropy, in the sense that I'm worried about my children and grandchildren. My second question is rather more selfish, and that is that the first thing that you said to me is that we don't have the answers, but we may have the answer in 5 years' time. That isn't much comfort, and I think there is an issue with a lot of people in my position, which is around their mental and emotional well-being. You know, for the medical profession to say we don't have the answer, hang on for 5 years, is quite a difficult thing for a lot of people to actually be able to deal with. I mean, the way that I do it is to have quite an intensive involvement in cardiac health advocacy. But I think there's a question out there for those people who need to be able to have something to work with, something to something to allow them some form of closure in the meantime.
Yeah, I think I would say to you, Paul, that we have treatments we have now that we didn't have 20 years ago, and we have a much better understanding about how those treatments work in terms of what we call antiplatelet therapy, aspirins and various ticagrelors and clopidogrels and prasugrels and all those kind of treatments. We have much better ideas about the benefits of statins and high dose statins, and with that other medication, what we call ACE inhibitors that you'll probably be on, and other cholesterol lowering medications. So I think that, yeah, I think there are treatments, there are good treatments now, and we're better at picking up those problem patients early than we were. I think just as a medical profession, I think we've got to say we've got to be honest. We will never have. We're not God, as much as the medical profession sometimes likes to think it is. We are. We're humans, and therefore we'll never have all the answers. The nature of medicine is to continue to search, to continue to learn, and that's at one point fascinating for the jobs we do, but on another point frustrating. Very frustrating for you, I understand, but also frustrating for ourselves. So I'm sorry we can't give you all the answers. I think we're much better than we were even 20 years ago, but my hope is we will be better again in another 20 years.
So I think that my third question is really introducing Dave McCormick, in the sense that I'm still not sure how to raise this issue with my son. Over to you, Dave.
Thank you, Paul. Thank you, Rhys. And thank you, Claire, also. So I think how to raise this with your family members and to have that discussion around the difficult issue of counselling and genetic counselling specifically. And Rhys has already touched upon this, but so forgive me for repeating it, but we are still at the very beginning, and I grant you that's no comfort either to you, Paul, or your family, or indeed to myself, because I myself have had a history of cardiovascular incidents. I had a heart attack a couple of years ago also, and I'm one of those strange individuals who's got a very, very low cholesterol level, or annoyingly so for a gentleman in his early 50s. But nevertheless, there was a blockage which was removed and stented, thankfully. And I'm on a variety of medications now to ensure my blood remains thin or thinner and keep things on the even keel. But to explain why that happened, given my unusual background, is still a bit of a mystery. It doesn't help, but to put it in some kind of context, not so long ago, Rhys or Claire, correct me if I'm wrong, if you had a heart attack in, say, 30 years ago, plus it was open heart surgery. Today, it's an arterial puncture up through the arm, around using the amazing camera technology without a general anaesthetic, with the blasting away of the fairing and the blockage and the installation of a stent. Now that, for me, is an incredible development. No general anaesthetic, no open heart surgery where you have to cut open the rib cage and go into the heart and start doing things directly, but you go by the arm or up through the leg and the thigh. That's incredible. And for me, those developments will only continue. It doesn't give us all the answers. It doesn't solve the problems. But coming back to genetic counselling, caution needs to be struck here also, in that when you are getting a whole genome sequence test to look for things like genetic variations in relation to heart development and how that impacts upon you and your family, we need to be very careful what that data is telling us, because simply having a test which says, yes, you will have a heart attack at age 30, or no, you won't, is simply not possible. It's all about risk, to use your term, Rhys, and probability. We know from a lifestyle situation that smoking, drinking excessive units of alcohol, poor eating, no or low exercise, etc., are all factors. However, to get the full picture from a genetics perspective is going to take time. We only understand around 2% of those 3.2 billion base pairs of information and how they interact and work together. That information is going to become more readily available over the next 5 to 10 years, as you say, Rhys, with the various pieces of research that are going on into how the genome operates and how it works when looking at particular things like the development of the brain, the eye, the heart, or other organs, and how all of these things interact. But it's still going to take time. It's hugely complex. And the closest analogy I have is the personal computer. You think of the millions of switches and the millions of settings one can have on your computer at any given time, even more so with the human genome and the human body. So it's no great response, I'm afraid, Paul, but I believe that we are getting there. And it also has implications for other aspects of epigenetics, or how our environment impacts upon our genome, not just about the usual culprits around smoking, drinking, diet and exercise, but other things like exposure to chemicals, organophosphates, exposure to sunlight and ultraviolet rays, and the impacts on cancer and other components. We need to be more aware of these things, and hopefully over time, with the developments in the genetic testing and amazing studies such as the Generations study, which was born out of the 100,000 Genomes project, of which I was part of, where we're analysing families, not just individuals, but babies and family units, we'll get a better understanding of the genome and how it works, in this case, for the heart and probabilities of heart complications.
Thank you, Dave, and we'll bring this podcast to a close now. But a huge thank you to Claire, Paul, Dave and Rhys. For more information in relation to this subject, please visit our website. Bye for now.